Inside a skull under pressure, the presentation is simple. Most patients report only two things, a fever and a headache. But this overlap is a clinical mask. These symptoms can signal three divergent pathologies, each requiring a specific, immediate intervention to prevent permanent neurological damage. To navigate the diagnostic process, we use a decision tree that branches into three anatomical territories. The first path identifies meningitis, the inflammation of the meninges, specifically the dura, arachnoid, and pia mater. The second path is encephalitis. Here, the inflammation bypasses the protective layers to attack the brain parenchyma itself. The final path is a brain abscess, characterized by a localized pyogenic capsule walled off within the tissue. Because empiric treatment must begin before laboratory confirmation, survival depends on tracing these vague symptoms back to their specific anatomical and microscopic origins. Without immediate imaging, the bedside examination must isolate signs that identify exactly which structure has been breached. Meningitis presents through meningismus. We look for nuchal rigidity, where the neck resists flexion, and positive Kernig's or Brudzinski signs. These maneuvers indicate physical irritation of the spinal roots and the meningeal sheath. At this stage, the brain tissue itself is typically not being destroyed. Encephalitis demands a different set of markers. Clinicians must look for cortical signs to confirm parenchymal involvement. These manifest as higher-level functional collapses, sudden altered mental status, cognitive or behavioral shifts, and aphasia. Direct irritation of the parenchyma also creates a high incidence of new-onset seizures. A brain abscess presents with neither diffuse meningeal irritation nor general cortical shifts. Instead, it creates focal neurologic deficits. Deficits like hemiparesis or cranial nerve palsies map to the physical location of the pyogenic capsule as it compresses specific neural pathways. Categorizing these findings into meningeal, cortical, or focal signs identifies the primary anatomical target of the infection. Identifying the target is only the first step. To treat it, we must understand how the pathogen breached the system in the first place. In acute bacterial meningitis, the primary route is hematogenous seeding, starting in the nasopharynx. Streptococcus pneumoniae colonizes the respiratory mucosa and breaches the barrier to enter the local capillary network. The bacteria travel through the systemic circulation and up the carotid arteries to reach the circle of Willis at the base of the brain. From there, the pathogen crosses the blood-CSF barrier, triggering rapid, diffuse inflammation throughout the subarachnoid space. Clearing these encapsulated bacteria from the bloodstream relies on a healthy, functioning spleen. This makes asplenia, whether through sickle cell disease or surgery, a significant risk factor for lethal S. pneumoniae or N. meningitis infections. As the infection spreads, the resulting cytokine storm can inflict direct damage on cranial nerve 8. This localized inflammatory response is what leads to permanent sensory neural deafness in survivors. Physically tracing this hematogenous route connects a benign respiratory exposure to irreversible sensory loss. While most meningitis pathogens move through the respiratory tract, Listeria monocytogenes uses the gastrointestinal system. Ingestion of contaminated deli meats or unpasteurized dairy allows the bacteria to enter the gut. However, in a host with a healthy immune system, Listeria is rarely able to breach the central nervous system. A neuroinfection only occurs when the patient fits a specific host vulnerability matrix. These risk factors are precise: age over 50, chronic alcoholism or cirrhosis, immunocompromised states, and pregnancy. Only in these vulnerable states can the bacteria bypass GI defenses to survive the bloodstream and seed the meninges. The patient's medical history acts as a predictive tool, allowing for the identification of a non-standard pathogen before the lab results arrive. Returning to the cortical signs on our diagnostic tree brings us to herpes simplex virus 1. This is a pathogen where a lack of immediate treatment correlates with a 70% mortality rate. HSV1 reaches the brain through a mechanism that ignores the blood-brain barrier entirely. This process is known as retrograde axonal transport, where the virus moves backward along peripheral nerve fibers toward the ganglia. The virus can remain latent for years. When an immunosuppressive event triggers reactivation, it travels along the nerve pathway directly into the brain parenchyma. By utilizing the nervous system's own infrastructure, the virus bypasses the vascular defenses that stop other pathogens. Once it reaches the brain, HSV1 shows a devastating localization within the temporal lobes. This targeting explains the clinical presentation. memory impairment in the hippocampus, behavioral shifts in the amygdala, and aphasia in Wernicke's area. Memory loss and behavioral changes are the physical consequences of the virus dismantling the temporal lobe's specialized architecture. These anatomical and pathogenic deductions find their ultimate purpose in the selection of empiric pharmacological therapy. Each terminal node on our decision tree corresponds to a specific drug formula. The baseline for acute bacterial meningitis is vancomycin and ceftriaxone. This provides broad coverage against primary threats, Streptococcus pneumonia and Neisseria meninginitis. If the patient fits the vulnerability matrix, over 50 or immunocompromised, ampicillin is added to cover listeria. When cortical signs are present, acyclovir must be added to the regimen immediately. Delaying acyclovir in the presence of cortical signs allows HSV1 to continue its destruction of the temporal lobe, leading to a high probability of death. Effective management of CNS infections rests on translating bedside signs and pathogenic routes into immediate, targeted pharmacology.